let me share the screen, sorry. No recommendations as far as like how to take their medications, except for to tell them that they need to follow the instructions from the physician and reinforce that. Okay, so we'll go into more detail about that as well. Okay, so chapter 28, concepts of orthopedic pharmacology. I'm mostly going to be reading from the slides here. There's not any hidden information because, again, it's pretty straightforward, the stuff that we're going to talk about. Okay, so the key terms, you're welcome to read these on your own. We'll talk about all of these, I believe, at some point or another. So the basic principles of pharmacology, we need to know, have some understanding of knowledge of interaction between medications and treatment, and how certain medications might affect our treatments. In other words, if a patient has taken a medication that one of the side effects is leaving them drowsy, we will have to have some understanding that either their physical therapy sessions maybe come at times when that medication hasn't kicked in full force, or we just have the understanding that the patient will be drowsy depending on the situation. Okay, so just having some understanding of side effects like that. And then we'll introduce key concepts that the PTA needs to provide for optimal care, and understanding of infections, pain, inflammation, and osteoporosis, and the medications regarding those diagnoses. So quick definition, pharmacokinetics. So this is a term used to describe what the body does to a medication. Okay, there are 4 phases of pharmacokinetics. The first one is absorption. So absorption refers to the process by which a drug enters the bloodstream from its site of administration. So either orally, intravenous, intramuscular, however the body starts to absorb that medication, okay? The drug must pass through various biological barriers, such as the GI tract or blood vessel walls, in order to reach systemic circulation. And then just a note here, topical absorption can be increased with heat. Therefore, it's important to not use heat or heating modalities near a transdermal medication patch. So if your patient has a patch on it, check to see if it's a medication patch, including those that are used for nicotine if someone's trying to quit smoking. We don't want to put heat near something like that because it's going to increase the absorption of that medication, and that may lead to too much of that medication being absorbed too quickly. Okay, so distribution involves the movement of a drug through the body after it has entered the bloodstream. So once it's in the bloodstream, how does it become distributed? So the drug may bind to plasma proteins or distribute into various tissues and organs, depending on factors such as the drug properties, blood flow, and tissue permeability. So we've talked a lot about that blood-brain barrier and how it's hard to get medications to the brain because a lot of medications cannot cross the blood-brain barrier. Its security system, if you will, is much more high-tech, and a lot of medications cannot penetrate that wall, okay? So that's why it's kind of hard to treat, like, it's hard to treat infections of the central nervous system. There are medications that can cross the blood-brain barrier, and there are other kind of pathologies that can cross that wall as well, but it's a lot more difficult, okay? So it's possible that we have to understand that it's important for meds to penetrate where they are needed, okay? That will depend, of course, the physician will prescribe medications, but it's just good to have some kind of understanding of distribution in that sense. Okay, metabolism is the next step. Okay, metabolism, also known as biotransformation, involves the enzymatic conversion of a drug into metabolites. This process primarily occurs in the liver, but can also take place in other organs. So metabolism can alter the drug's activity, facilitate its elimination, or generate active or toxic metabolites. So this is what our body does to the drug, changes it in some form or another. And that either is changing it in order to facilitate elimination from our body, or maybe it's changing the drug to our benefit, okay, whatever our body is doing to metabolize that drug, okay? And then the last step is elimination. Elimination refers to the removal of a drug and its metabolites from the body. So the primary route of elimination is through the kidneys via our urine, renal elimination, okay? But drugs can also be eliminated through other routes, such as through the GI tract, i.e. feces, through our lungs, skin via sweat, or via breast milk. That's why sometimes they say that with a lot of new moms with the COVID vaccine, that if you got vaccinated against COVID, there was some thought that newborn babies who could not get vaccinated had some level of protection if they were breastfed, because some of that kind of elimination style is through the breast milk. So just an interesting thing to think about, okay? The elimination process usually follows first order kinetics, where a constant proportion of a drug is eliminated per unit of time. Okay, so in other words, our drug, depending on the drug, it leaves our body in kind of a different proportion, kind of depending on the drug. Okay. So that being said, now we're going to talk about how much of it is leaving our body. So half-life, the term half-life. So half-life, the half-life of a drug refers to the time it takes for the concentration of the drug in the body to decrease by half. Okay, it is a measure of how long it takes for the body to eliminate or metabolize half of the drug. So that's why knowing the elimination and the half-life of a drug becomes important, is that you don't want to accidentally overdose on a medication because the half-life is slow for that drug. And you don't realize that your body hasn't eliminated that drug yet. So therefore, and you take more of that drug, now you're increasing the amount of that drug in your body. This is why it's important for us to make sure patients follow the labels on their prescription drugs. It sounds silly, but a lot of patients won't, right? And if they are taking, let's say, Norco for pain, and it says take every 4 to 6 hours, and they're taking it every 2 to 3 hours, that drug is starting to build up in their system because the half-life is slower on that drug, right? So, again, we don't need to know so much detail about drugs, but we do need to have some understanding of why we're telling our patients to do what we're telling them to do. Okay, in other words, follow the labels, follow what your physician told you to do. The half-life of a drug can vary significantly depending on the specific drug and various factors such as the route of administration, metabolism, and excretion mechanisms. Some drugs have short half-lives, meaning they are rapidly eliminated from the body, while others have long half-lives, indicating a slower elimination process, okay? The half-life of a drug is an important parameter as it helps determine the dosing frequency and duration of a drug. For example, if a drug has a short half-life, it may need to be taken more frequently to maintain therapeutic levels in the body. On the other hand, drugs with long half-lives may require less frequent dosing. Anything that slows a drug's clearance lengthens its half-life. Liver metabolism and renal clearance are slower in older adults compared with younger adults. Likewise for persons with acute or chronic liver or kidney disease. So if your kidneys are not working properly and it's a drug that is metabolized via the kidneys, their half-life is going to be much slower, right? The drug will be in their system for longer. The most common type of clinically significant drug-drug interaction occurs when the presence of one drug slows the metabolism of a second drug. So if there is a drug that's affecting how you're eliminating another drug, you're going to have both drugs in your system, possibly on accident, right? That's why what they call medication reconciliation in home health becomes important. You're giving the doctor a list of what the patient is actually taking, and they're able to put it into a system, and actually you are too via your home health paperwork, or the PT will, to see, are there any drug-to-drug interactions that are important to take drugs not at the same time? In other words, they might have a patient take this drug in the AM, this drug in the PM, because those drugs should not be entering your body around the same time, okay? So another term, duration of action. A medication's duration of action, the length of time it is active in the body, is related to its half-life. Drugs with a long half-life have a long duration of action. Medications with a short duration of action usually require multiple day administrations 3 or 4 times daily, whereas medications with longer durations of action may require dosing only once or twice daily. One way medications can overcome a short duration of action is if they are formulated as a sustained release product, okay? So a sustained release product is usually in tablet or capsule form and is specially designed to dissolve very slowly in the intestines. By dissolving gradually over 12 or 24 hours, its effect lasts longer. In general, sustained release products should not be chewed, crushed, or broken up. Doing so can destroy the product's sustained release properties, causing the entire dosage to be released at once. The way that I think about this is how I remember it is if anyone has ever put M&Ms in the microwave, and maybe that was just something I did as a kid, but if you think about an M&M, it has that candy coating that's holding all the chocolate in. If you put an M&M in the microwave and it's kind of melty on the inside, if you break it open, that chocolate kind of spills everywhere. In other words, the inside of the drug is getting released quickly all at once. Versus if you're just kind of have an M&M in your mouth and you're kind of slowly letting that candy coating dissolve, you're kind of slowly getting that dose of chocolate. Okay, so in other words, if patients have a sustained release product, especially like this will happen with pain medication, where it'll be like an extended release tablet, they cannot cut it in half because they're cutting into that like candy coating of the M&M and letting all that chocolate spill out too quickly. Okay, so again, we don't have to go into so much detail, but we do need to know you cannot cut a sustained release product in half if a patient will do that when they feel like they don't need as much pain medication, right? Well, I felt like I didn't need that much Norco, so I cut the Norco in half, right? Double check the bottle and you check to see, was this a sustained release, right? If it is, then that's a problem that they cut it in half, right? They're going to get too quick of a dose too quickly. Okay, pharmacodynamics. Pharmacodynamics is used to describe what the medication does to the body. It's a study of the relationship between the amount of drug in the body and the response observed. Pharmacodynamics includes a wide variety of principles such as the dose-response relationship, therapeutic window, adverse reactions, and toxicity. So pharmacodynamics kind of encompasses all of those terms, and we'll talk about each of them kind of briefly. So the dose-response relationship. The dose-response relationship refers to the relationship between the dose or concentration of a medication or substance and the biological or physiological response it produces in the body. It describes how the magnitude of the response is influenced by the amount of substance administered. Okay. In general, the dose-response relationship can be represented by a curve known as the dose-response curve. The curve shows a relationship between the dose or concentration on the x-axis and the magnitude of the response on the y-axis. The dose-response relationship typically demonstrates three key characteristics. It shows a threshold, in other words, what's the minimum amount of that medication you need for any kind of effect to occur. The efficacy, as the dose or concentration increases, the magnitude of the response should increase as well. Okay, and the maximum response. Beyond a certain dose or concentration, increasing the dose does not lead to a further increase in the magnitude of response. So the maximum response would be, after this point, you take this much drugs, it's no longer going to have a therapeutic effect if you continue to take more. Okay. The dose-response relationship is essential in determining the appropriate dose or concentration of a medication for achieving the desired therapeutic effect while minimizing adverse effects. It helps guide healthcare professionals in establishing safe and effective dosage regimens for patients. And a lot of times what I go back to are patients who have Parkinson's disease, who have to take medications kind of around the clock in order to treat their symptoms. And the doctors are constantly having to kind of adjust their dose or maximum to make sure they're not hitting maximum response, to make sure they're still on that efficacy curve, making sure they still have that threshold hit. Okay. So it's kind of playing a game with some diseases, probably for some physicians, trying to figure out how much of the right medication is good for the patient. So there's a picture for you showing the maximum efficacy where the response kind of levels out a little bit. In other words, the response is no longer kind of increases as you increase the dose. And then there's, isn't a picture here, but at some point there's that threshold that's hit where you actually feel a difference in the way that your body responds to that medication and you have those benefits of the medication. Okay, the therapeutic window. So a drug's therapeutic window may be described as wide or narrow. The window is defined as the minimum drug concentration needed for the drug to show effectiveness without causing toxicity in the patient. Okay, so the therapeutic window can be thought of as well as that between the threshold and the maximum response, right? When you're thinking about side effects as well. Okay, so that window is the amount of drugs that a patient can have without increasing the toxicity and then therefore increasing risk to the patient as far as the side effects or the toxicity of the drugs go. So most antibiotics have wide windows. Anticoagulant medications tend to have narrow windows, right? Their threshold and their max efficacy is more narrow, okay? So adverse drug reactions, okay? So in other words, side effects or an exaggerated response of the purpose of the medication. So an example might be medication to treat high blood pressure could have a side effect of causing hypotension, right? That makes sense. It's going to say it on the bottle. If you take too much of this medication, your blood pressure might drop too low. And then you have signs of maybe orthostatic hypotension with standing or whatever it is. What was the other example? Oh, another side effects or an exaggerated response might be like a muscle relaxant, right? If you get a muscle relaxant, yes, it helps to loosen the muscles, but it's also non-specific. People tend to be very, very drowsy if they've taken muscle relaxants. So that would be like an exaggerated response or an adverse drug reaction. Okay. So medications may affect cognitive function as well. Okay. So if you are drowsy, you're going to have decreased cognitive functioning while that medication is in your body. So it's important for us as clinicians to know, does this medication increase the risk that my patient has for a fall? If my patient's telling me, oh, I take my medications and then about an hour later is when I usually have a fall mid-morning, right? You can go back to that medication list. And again, we are not here to change their medications or tell them how to do it, but it might be something worth letting the PT know and letting the patient know, hey, when you take these medications, you can't be like just choosing that to be your time to do the balance exercises I gave you, right? That's not a good time to do them. And then as far as the last thing you should do as well is let the physician know, hey, my patient's having increased falls mid-morning right after they take this medication, right after this medication seems like it's kicking in, right? They might not do anything, chances are they won't, but at least you've done your job letting the physician know, letting the PT know, and making sure you're educating the patient on importance of maybe not doing crazy balance activities right after taking or within the window when that medication would be working. Okay, toxicity. Situations where the serum concentrations have exceeded normal limits occurs when the concentration of the drug in the body reaches levels that can cause damage to the organs, tissues, or physiological processes. This can be from an overdose. It can be cumulative toxicity over time. If a drug has a slow half-life and you're kind of slowly increasing a cumulative amount of drug in your body, that could be cumulative toxicity. Or it could be from drug interactions. Two drugs you're not supposed to take together, they have a similar toxicity level, or whatever they're doing to the body is similar, and you accidentally take them together. That could also lead to an overdose. Okay, more terms for you. So withdrawal symptoms. Withdrawal symptoms indicate physical dependency and are expected to occur with prolonged periods of medication use. Okay, so symptoms are generally the opposite of the pharmacological effect. So example, one withdrawal symptom of a medication used to treat high blood pressure would be hypertension. You stop taking a drug in order to decrease your blood pressure, your body then goes through withdrawals and you might have heightened blood pressure while you're kind of trying to withdraw from that medication. This is why they have patients kind of decrease certain medications slowly from their body. For instance, prednisone, right? If a patient is kind of decreasing the amount of prednisone in their body, they're not stopping cold turkey. They're kind of slowly easing their way off of something like that. Now, addiction is a little bit different. Addiction is a psychological dependency, so a strong craving or a desire for the drug that overwhelms daily life. So as you can see, withdrawal is more a physical dependency. This is, by the book at least, a physical dependency. Addiction is a psychological dependency. So this is especially concerning for medications that have abuse potential, like sleep aids or pain medication. Patients may continue to use these substances to avoid withdrawal symptoms as well. Okay, principles of safe medication use. So we are not involved in the decision-making process regarding prescriptions and over-the-counter medications, but we can and should have a general understanding of some commonly used medications. Patient education is important for medication management, as well as keeping track of and alerting the PT or the doctor, preferably both, for any changes in medication or non-compliance with medication instructions, okay? Various drug information resources exist that can be helpful in providing you and the patient with relevant information. So, principles of safe medication. What can you do as the PTA? Here are the general principles of safe medications that can be used, can be provided to the patient. So, you're telling the patient, keep a current list of all their medications they're taking, including over the counter, because those can have some drug on drug interactions that we need to worry about. Keep medications in their original container so there's not any accidental switching medications. Never take someone else's medications. Take medications exactly as directed. Do not start or stop medications without consulting the prescriber. Report any new symptoms to the prescriber. Don't chew, crush, or break any capsules or tablets. When measuring liquid medications, use only the measuring device provided just to decrease our risk of errors, and ask questions when things are unclear. Okay, I guess that's the end of the list. So these are the things that we can educate our patient on doing, okay? Medications to treat and prevent orthopedic infections. So now we'll just talk about a couple different categories of medications. So antibiotics are to kill or inhibit a growth of bacteria. Okay, they don't treat viruses. That's why we don't get antibiotics for COVID. We get antibiotics for a bacterial infection. Infections slow to recover, cause permanent joint damage, and lead to non-union and fractures and death due to sepsis. So it's very important to treat infections if we need to with antibiotics, okay? They're selected based on suspected or known pathogens, a drug's ability to distribute adequately to the site of the infection, patient drug allergy history, side effects, and cost. Antibiotics routinely ordered to prevent or treat infection preoperatively and postoperatively are called prophylactic. Okay, if you're taking a medication that's prophylactic, you are taking a medication to prevent an infection from happening. Maybe a patient who has recurrent urinary tract infections might be on a prophylactic dose of antibiotics in order to decrease their risk of continuing to get urinary tract infections. And sorry, I kind of skipped that second to last bullet point, but they are routinely ordered to treat infection pre-op or post-op. So patients might get it pre-op or post-op. They'll also get it as a prescription, just in case they need to have dental work after having surgery to decrease the risk of an infection. So a quick definition, prophylactic. As I said, a patient might be given an antibiotic prophylactically if they have recurrent UTIs. That's the most common thing you see, especially in geriatric population. But those are known as, they are preventative medications. Drugs that are prescribed to prevent the occurrence or reduce the frequency and severity of certain medical conditions or diseases. These medications are typically prescribed to individuals who are at a higher risk of developing a particular condition or those who have a history of recurrent episodes. So as I said, antibiotics and vaccines is another type of a prophylactic medication, right? Vaccines are a type of prophylactic medication that help to prevent infectious diseases. We get the flu vaccine every year prophylactically in order to decrease the risk of getting the flu. They stimulate the immune system to recognize and fight specific pathogens, providing long-term protection specifically for vaccines. Medications to treat and prevent orthopedic injuries. So again, just continued so compliance. We're supposed to take the medications or administer the medications as prescribed. Do not stop taking antibiotic until all the doses are completed. That's important because patients will say, well, my UTI seemed to go away after 3 days, so I stopped taking the antibiotics. Uh-oh, that's a problem. You have to finish the full dose. Usually it's 7 to 14 days, whatever it is. They have to finish the full dose of antibiotics, even if they're feeling 100%, okay? Medication to treat pain and inflammation. So These medications are not only reduce suffering, but also speed healing. Okay. Pain compromises mobility. That's important for us to know, right? If a patient is in 10 out of 10 pain and can't kind of do their exercises, they can't stand up straight because of pain, they can't do all of these things, they can't sleep at night, they're going to have an effect on their quality of life. So it's up to us to also make sure, are you taking your pain medications? Did you take them today? Okay, then we can move on with therapy, right? So pain is often undertreated, even though I think the global kind of scariness of taking too many pain medications is out there. A lot of times pain is actually undertreated for our patient population. And that might be because of the physician, but it also could be the patient is just scared of getting addicted to pain medications and undertreat themselves. Okay. So pain is a treatment priority. So pain affects function, therefore has a direct effect on PT goals. Pain is considered, according to your book, the fifth vital sign. So regular assessment and documentation of pain severity, functional ability, progress towards goals for patients of all ages is important. In other words, we are documenting what they are telling us their pain levels are. So hopefully we can see a pattern where it's starting to decrease, and then they actually can maybe decrease pain medication, right? We're sometimes having to tell patients you need to follow the instructions from your physician because it's actually going to help in the long term. If you can treat your pain now, we can get you stronger. Maybe at some point you don't have to be on that much pain medication, right? Again, we don't get to decide any of that, but it's just throwing it out there that pain has a really big effect on their mobility level. Okay, analgesics to reduce pain. So an analgesic is any medication that reduces pain. So there are three types of oral that you can take orally or intravenously: opioids, acetaminophen like Tylenol, and anti-inflammatories like Advil, ibuprofen. Okay. So pain meds are prescribed by a physician or a nurse practitioner based on the following: type of pain, level of pain, the side effects of those medications, and the cost to the patient. Okay, types of pain. So we have nociceptive pain, results from tissue damage, right? That's noci pain, kind of our nociceptors in our body. So that can be inflammatory or non-inflammatory, or it can be both, right? Osteoarthritis, bone pain, sprains, post-surgical pain, bursitis, those are all inflammatory nociceptive pain. Anti-inflammatory medications for inflammatory pain, a good example would be Motrin, ibuprofen. After you've had an ankle sprain, if you go see the physician, a lot of times, depending on the patient, but a lot of times, one of the things they tell you to do is take ibuprofen or Motrin to help decrease the swelling, or they'll prescribe a dose that's high enough to actually treat the swelling. Okay. Okay, neuropathic pain. This results from damage to or dysfunction of a nerve. Okay, nerve. Nerve compression, fibromyalgia, diabetic neuropathy, spinal cord injuries, or phantom pain are all considered kind of neuropathic pain. So these are relatively resistant to opioids, acetaminophen, and anti-inflammatory agents or NSAIDs. But there are pain medications that slow or block nerve conduction, and these tend to be the more popular ones for neuropathic pain. So if you have patients who are on antidepressants, some form of an antidepressant like Cymbalta, as well as anticonvulsants, so Neurontin, Lyrica, those tend to be kind of ones that you see a little more often. Lidocaine patches, Ultram, which is an opioid analgesic, and Tramadol. Tramadol tends to be a popular one as well. So it's an opioid with antidepressant-like properties on nerve conduction. All of those are to treat neuropathic pain. So just because your patient maybe has an antidepressant medication doesn't actually mean that they are on it for depression. A lot of times it could be from neuropathic pain that they have. And persistent pain. Persistent pain is either acute or chronic. So it generally responds better to around the clock dosing rather than on demand dosing. So you're not trying to catch up to the pain, right? You want to kind of stay ahead of the pain with persistent pain. So the example would be status post, a total hip replacement, a total knee replacement. That would be more acute, and chronic pain would be more of a persistent pain that's more chronic, and that would be pain that lasts 3 months or longer. It responds well to opioids, acetaminophen, NSAIDs. Okay, so chronic pain patients may be prescribed medications that have a long duration of action, or sustained release medications. So how long the medication is doing something to your body would be that long duration of action. Now, breakthrough pain is something where even if you're taking pain medication to treat that persistent pain, the pain kind of breaks through. So, breakthrough pain medication would be maybe another medication that's given to patients as like, if you need to take this medication, you can take this one once a day, something like that. An example would be a lot of times patients who have total hip or total knee replacements. Yeah. Okay, I'm almost done. Can you go downstairs? I'm almost done, baby. Thank you. Okay. Sorry. Okay. So breakthrough pain is pain that occurs despite, as I said, sorry. So breakthrough pain can be treated if a patient is on like some kind of pain medication after surgery, but then they're also given a dose of tramadol and they're told once a day, if the pain is that bad, you can take a tramadol to kind of treat that breakthrough pain. Okay. So that's what they mean by breakthrough pain. Opioid analgesics, okay? So these are chemically related to opium, so morphine, oxycodone, hydrocodone, or codeine. They work by blocking the central nervous system transmission of pain, so a little different, and they create a feeling of euphoria. These, like all pain medications, treat the pain, not the underlying disease, okay? So epidural and IV opioids can be used in the hospital and topical patches can be used at home, but these affect the central nervous system. So their side effects can be a little bit more significant. Nausea, vomiting, sedation, drowsiness, dizziness, constipation, impaired judgment, and a risk of injury from falling because of that drowsiness and impaired judgment. Healthcare providers and patients may overestimate the risk of developing addiction when managing pain with opioids. This misperception can lead to inadequate pain control through underprescribing or underdosing, and patients skipping doses or taking as little as possible. So again, we're probably undertreating our patients rather than overtreating. When I say we, I mean us as a nation, not physical therapists and PTAs, because again, we do not have any say in this necessarily, except for to monitor our patients and let the physician know what's happening and educate our patient to maybe follow up with the physician as well if we're concerned about something like this. Okay. So the actual risk of developing an addiction following long-term use for an opioid is difficult to assess, but is estimated at 0.2% for persons with no prior history of substance abuse and 3.3% for the general population. Okay. So tolerance and dependency are not equivalent to addiction. So just going back to that addiction versus withdrawal symptoms. So tolerance or dependency is physical and addiction tends to be more psychological. And there's just a chart for you talking about the opioid epidemic. It is 100% real and 100% scary. At the same time, there's so much buildup that patients get afraid to take medication at all, and they could be in very, very severe pain, unable to move, get out of bed, and not following the orders from their physician becomes important because they could actually put in themselves more in danger of having long-term mobility issues if they don't treat the pain the way that the physician has asked them to. Okay. Acetaminophen, so this is the most commonly used over-the-counter fever reducer, used for headaches, sinus pain, back pain. We've probably all taken Tylenol in our lives at one point or another. It does not have the strong anti-inflammatory properties of NSAIDs or Advil. Okay, so if you're trying to treat, if a doctor's trying to treat an ankle sprain and there's severe swelling, yes, they can take Tylenol for the pain, but it's not going to change the swelling at all. Versus NSAIDs, a lot of times have that anti-inflammatory property as well and treat the inflammation and the pain. So they can be contained with other medications. Very common for patients to have some kind of like hydrocodone and Tylenol in the same tablet. So it's important for patients to read their medications and have a good understanding that they can't take Tylenol on top of Tylenol on accident if they don't realize that one of their medications prescribed from their physician after surgery already has Tylenol in it. Okay, so that's common for total hip and total knee patients. So can be given to patients with a history of GI bleeding, okay, congestive heart failure, or hypertension. Okay, Tylenol is safe for all of those people. Overdose, hepatotoxicity is the most likely thing that can happen with taking too much Tylenol. So the label says 3+ alcoholic beverages per day. Ask your doctor whether you should take this medication, right? Because if we are already consuming 3 doses or 3 alcoholic beverages a day and taking Tylenol, that's a lot on our liver. Okay. So just being aware of if your patients, oh, you're taking Tylenol on a daily basis for your pain. How much are you drinking? Do you drink? Right. And in a completely non-judgmental way. We don't want to judge our patients. At the same time, we need to know if they're putting themselves at risk for a possible toxic level in with their liver. Okay. And NSAIDs. So these are aspirin, ibuprofen, kind of more other ones that we kind of hear about over the counter. So they're also available as an injection. They reduce a fever and inflammation, found in a variety of cold medications and some sleep aids. Okay. And aspirin. So aspirin use in children is never okay. It causes a fatal illness known as Rey syndrome. Okay. But in adults, aspirin is used prophylactically as it decreases the risk of a stroke because of some kind of property where maybe it's having kind of like a blood thinner effect. So it's decreasing the risk of a blood clot. Okay. Don't quote me on that 100%. I'm not sure the exact physiology behind why it helps to decrease the risk of strokes, but it will be prescribed for patients, just a baby aspirin on a daily basis for them to decrease that risk. Okay. It's not appropriate for all patients. If you are on blood thinners like warfarin or Coumadin, if you have congestive heart failure, kidney disease, ulcers, bleeding disorders, or alcoholism, then that's not, aspirin is not something that will be prescribed to you. Okay, COX2 inhibitors, Celebrex. This is the main one. I think it's the only one that we'll see, at least for now. So Celebrex is used to treat the same types of pain as ibuprofen and Tylenol, but it has a lower risk of side effects. Okay, it inhibits production of prostaglandins, if I said that right, by inhibiting the COX2 enzyme and not COX1. NSAIDs inhibit both. You do not need to know all the details of this, but what you do need to understand is that Celebrex is given for patients who cannot take NSAID, but would benefit from the positive effects of an NSAID. So there are fewer bleeding related and stomach related side effects with Celebrex. So more safely prescribed to patients because it has fewer bleeding related and stomach related side effects. Sorry, I said that twice. But it's still unsafe for patients who have hypertension, congestive heart failure, or kidney disease, okay, because the risk of fluid accumulation is still high for this drug, okay? And it's not prescribed to patients who have a sulfa allergy, which is a type of antibiotic. So a Celebrex can just be prescribed for patients where it's a little bit safer with bleeding related or stomach related side effects. Okay, corticosteroids, also glucocorticoids, are produced naturally by the adrenal cortex and are involved in regulating metabolism of carbs, proteins, fats, inflammation, immune function, wound healing, and many other body systems. When used medically, they have a powerful anti-inflammatory and immunosuppressant response, making them useful in treating conditions such as RA, osteoarthritis, carpal tunnel, acute gout, really anything where there is an inflammatory response or an autoimmune response from our body. So it's an anti-inflammatory and it's immunosuppressant. So anytime where those two things are happening, it can be used to kind of treat those symptoms of that disease. Okay. Corticosteroids are also common with patients who have maybe ulcerative colitis, right? They have an autoimmune disease. It's creating inflammation in their colon. Corticosteroids can be used. Okay, so injections provide excellent pain relief for joints with the advantage of local drug delivery. In other words, patients who've had a corticosteroid injection. This is important for us to know. So after injections, the patient should minimize activity and stress on the joint that was affected wherever they got the shots. If they have shoulder pain because of inflammation, they get a corticosteroid injection. We are not going to do physical therapy on that patient, okay? The effects from a single injection may last 4 to 8 weeks, and the most common injected joint is the knee, okay? Osteoporosis medication. These are just a list of some of the osteoporosis medications that you guys might see. You don't need to memorize this by any means, okay? But, and I think this is the last slide, yeah. Medical marijuana. Oops. Okay. Medical marijuana. So medical marijuana, this is just the last slide on this because it's becoming more and more popular where patients will ask your opinion on medical marijuana. And again, we can tell them we are not physicians. We cannot give our opinions or thoughts on medications, but it is good to have some understanding of what medical marijuana is, and having them follow up with their physician if they do have more questions about it. Okay, so medical indications for cannabinoids include neurological conditions such as MS, muscular dystrophy, Parkinson's disease. Some of the benefits: it provides a relaxing effect on our nervous system, allowing patients to be stretched in a more comfortable manner. May allow patient to tolerate Therax, decrease chronic pain, spasticity, and chemotherapy-induced nausea and vomiting. I would say that's where I've seen it the most is with patients who have undergone chemotherapy or patients who have chronic pain. It can have negative effects on our other systems, but it's still kind of being studied. It's not 100% clear what those side effects necessarily are. There's a lot of information out there, but again, you refer back to the physician when they have questions. All right, and that's it for the pharmacology lecture. Again, just have a general understanding of all of this. I'm not going to quiz you on super specific stuff, but just understanding our scope of practice as clinicians is the most important thing.